What is up, my friends? We are here on another episode of Level After Next podcast, where every week we're going to be your accountability. We're going to give you the inspiration. We're going to hopefully make you laugh a little bit. And at the end, you're going to have every desire to go forth and slay. So let's do this. I am here with Dr. Nerissa Prieto. You guys, I'm so excited to introduce you to this amazing human who came into my life just a few years ago. I'm not even going to pretend like I don't know and love her, because that would just be silly. She is here in Chico, has an incredible business that she's begun. But first, I want you to hear a little bit. I know that we already did this, but they need to hear your background, because I mean, you talk about it like it's no big deal, but your experiences all through college and where you've been, where you've studied, who you've gotten to work with, it's such a huge testament to what you are able to bring to the community and the medical community at this point. So start over. Tell us, how'd you get here?
I ended up in Chico through a little bit of a circuitous route. I was born in Connecticut. My dad was actually a physician who emigrated from the Philippines. My mom was a nurse who emigrated from the Philippines. I was born in Connecticut, raised outside of Washington, D.C., ended up in prep school outside of DC, and through my experience at that all-girls high school, ended up at an all-women's college, Wellesley College, up in Boston. So it's an interesting thing. I don't think you'll find a whole lot of cats like me who have 8 years of an all-women's education behind them, for better or for worse. The world is stuck with me. And after Boston, then I ended up moving to New York. Even though I'd had dreams and aspirations of being a physician, I thought I'd test the waters in what was the go-go 80s and started a little bit of an investment banking thing. It didn't last very long. I ended up in financial institutions, corporate finance, mergers and acquisitions for around a year, and then ended up doing essentially marketing and fundraising for a foreign currency hedge fund. So that was all great, except for the fact that it got a little crazy at the end of the 80s. And I realized that I really did want to stick with my original plan of going to medical school. While I kind of put that plan together, I ended up traveling a lot. I was telling Katie last night that I actually was a cocktail waitress for the Mafia in North Jersey, which was a year and a half of really eye-opening experience for me. By the time I was done with that part of my life, I had gotten into graduate school at UCLA, where I completed my master's degree in cell biology and neuroscience as sort of my first step back into the competitive world of trying to get into medical school. After I completed my master's degree at UCLA, I came back here across the country again to attend medical school and finished residency at Rutgers in central New Jersey. And after anesthesia, decided that I wanted to have a bit more breadth to my medical training outside of the operating room, even though anesthesiologists really have to be on-the-fly experts in everything from cardiology to physiology to pharmacology, which is one of the things I love about anesthesia, is sort of the breadth of understanding that we have in how to take care of patients and really identify very quickly how, when people might die and be able to do something. So it made sense then for me to continue with my education to go into critical care and intensive care unit. So I crossed the country again and ended up at Stanford doing my fellowship there. And then from Stanford was looking around at all the different job options, ended up getting pulled up into Chico around 17 years ago. So I've been in Chico ever since then. I've been in the operating room, trauma bay, to some degree the ICU, and certainly obstetrics, OBGYN, and practiced here in Chico for many, many years, and then ended up working up in Reading for 3 years. And now I'm primarily focusing on my private clinic, which was opened in 2021 under the business name Privy Modern Health. The objective there was sort of to bring a little bit of awareness to the general public, and this was right in the middle of COVID, of the idea that maybe nutrition has a lot to do with people's disease states and their experience with their health or lack of health throughout life. And certainly right at around 2021, when I started this business, vitamin D was high on the list of things that were being investigated as being really, really tied up and possibly predictive of people who might pass away, who might succumb to COVID. So that was really a great starting point for me. I think the general public became very aware very quickly of the fact that I think a lot of people have gone without education regarding nutrition, and we as Western medicine physicians don't have a lot of experience, don't have a lot of education, and really didn't have the tools to guide our patients. So that was really the driving force for me in starting this IV nutritional clinic.
So I think, like, just to back up a little bit, a lot of times people hear about the IV nutritional clinics, right? And immediately they're thinking like, oh, cool, hangover cure.
Certainly, if you have a hangover, you're dehydrated. Maybe you're not eating so well because you've been drinking so much. All of that makes sense. But with my ICU background and with my sort of interventionalist, let's fix what we can as quickly as we can approach to medicine, I really am approaching it truly from a nutritional perspective. And my real interest and the real soft place that I have in my heart has to do with understanding the needs for micronutrition and how they're different in sick people versus well people, in old people versus young people. And I've really dedicated my life. Sure, I'll take care of drunk college students and hungover 50-year-old people who can't handle themselves anymore. I'll do that all day long. But I really love being able to contribute some thoughts to people who suffer from chronic diseases. The idea of aggressive nutritional supplementation in the setting of treatment of chronic diseases, everything from obesity to diabetes to high blood pressure, and certainly neurologic and neurodegenerative disorders. That's where I've found my people. That is really where I think specifically neurodegenerative disorders is where I feel as if I've been able to make the most impact. And there's not a lot of medical literature that's out there with regards to the therapeutic use of vitamins in people with chronic disease. But certainly in the nutritional literature and the basic science literature, it all makes sense to me. And I think in my hands, certainly, it's very, very safe. And in a lot of cases can really be life-changing.
Well, I think it's incredible. I mean, there's no, and I don't want to open up a can of worms here, but I had mentioned to you at one point that I was really like indoctrinated at a certain point in my life to think like, oh, supplements are just silly. They're just, mega doses. You're not taking any of them. And I realized that you're not actually absorbing. Bioavailability is huge. I know that the way that you are utilizing and, treating people with these is completely different, especially with your knowledge. And I'm sure that obviously supplements are going to have different levels of
efficacy. Sure.
Efficacy. Yeah. But I also know that when we go see a doctor, I haven't ever had an actual one of my doctors say, start taking, these vitamins, go to New Earth and get this supplement. It's a medication, and typically that's it. And so as I have evolved in my career and started to really learn more about supplementation and the impact of all of these, like you said, micronutrients and things that I've never even knew existed that are so incredibly important to us and how they've impacted my own health, this makes all the sense in the world. And how are we going to clone you like 8,000 times to make this available?
This is a huge issue. It's funny. Do you mind if I ask what it is what problem were you looking to solve by taking all of these supplements, Katie?
So, I mean, I've had a number of different issues, but, number one is endometriosis from the time I was very young. And that was just painkillers. And I mean, it's basically painkillers and birth control was all I could be given. Right. And then I did have a doctor who understood it well. But still I went through a menopause in my early 20s, chemically induced menopause. And then was just told have babies and nurse until you're ready for a hysterectomy. And so there was no
how old were you when that happened?
Menopause.
Well, so they were you've had 5 surgeries for this? Yes. Okay. So it is an interesting thing because endometriosis, like so many other different disease processes, is based in an inflammation, right? So the number one things that you have to look at from a vitamin micronutrient perspective, always start with vitamin D. Vitamin D ended up being at the center of the entire increase in awareness of the importance of nutrition when we were all going through the whole COVID pandemic situation, worried, how are we going to figure out who's going to die and who's not going to die? So much of it ended up being related to comorbidities, but it turns out that the biggest comorbidity, the biggest thing associated with death from COVID, one of the biggest things, is actually being overweight or obese. And guess what ends up happening when you're overweight or obese? You end up with profoundly depleted vitamin D, because vitamin D is one of 4 fat-soluble vitamins. And if you have a lot of excess tissue on you, the vitamin D gets dragged into your fat stores and away from your immune system. And so the people who had low vitamin D, because of their being overweight or their being obese, were the ones that were tending to die of COVID in the ICU from these massive inflammatory responses that essentially ended in organ failure. So while certainly your endometriosis obviously is not currently a life-threatening thing, it is also based in inflammation. Vitamin D acts as the captain of the ship, so to speak, of the immune system. And low vitamin D is associated not only with death from COVID, but is also associated to some degree with good control versus bad control of endometriosis and symptoms, including pain. And for instance, it's also significantly playing a part in the progression, stabilization, and management of diabetes, as well as autoimmune disorders. So whenever you talk about anything, any disease process that involves inflammation, and there are a lot of them, vitamin D is something that I think does need to be looked at very, very closely. Of course, the biggest problem with that, even though I could tell you, Katie, to reduce inflammation. So you have endometriosis, you have this inflamed uterine lining that's spitting out all of these cells all over your insides that in turn start to grow because blood vessels are attracted to these little islands of abnormal tissue in your innards. And that attraction of the blood vessels is also inflammatory based. So in theory, controlling the inflammation with maintenance of vitamin D as well. I can't say that there have been any studies at all that I know of that show that taking vitamin D is going to prevent your having pain and progression of your endometriosis. But certainly they have demonstrated in at least a few small studies, maybe not so well studied, but there's definitely a relationship between people who have bad endometriosis and a variety of different micronutritional deficits that include vitamin D, vitamin C is another one, vitamin A, and to some degree, some of the B vitamins, all of which are involved in sort of inflammatory responses in general. So if you know that these supplements are safe and you feel as if they've been able to help your pain, then the next question becomes, how do we, as practitioners, as physicians trying to take care of our patients, take the information that we know and be able to get the information out there? And unfortunately, we're really in a bind because the way the FDA process, and I'm saying this and I know you're thinking in your head, aha, I know where she's going with this, but the way the FDA process works is that in order to approve the use of vitamin D for this indication or for that indication, you need to have what's called a double-blinded placebo-controlled study, which means thousands of patients, which means one arm of the patients is treated, the other arm of the patients is not treated. Well, who the heck is going to pay for that when we're talking about vitamins? I mean, that's the big question. So to set that as the bar is unreasonable, in my opinion, because that kind of data will never be funded. We'll never have an answer. And to say then that, well, there's no evidence to support that taking vitamin D will reduce the likelihood of your having an autoimmune disease, you can't say that and then just ignore the basic science. The basic science says that your immune system depends on the complex interaction of dozens of different micronutrients. The FDA sort of barrier, this double-blinded placebo-controlled study, also demands that an individual molecule that's being studied for how effective it is to treat fill in the blank has to be experimented with in isolation. So of course, going back to the COVID concept, people noticed that the people dying of COVID had extraordinarily low levels of vitamin D. So there were a few studies that were conducted in the ICU with dying patients where they said, we have 2 dying patients, we're going to give one of them vitamin D and one of them no vitamin D. And lo and behold, there was no difference at all. Well, of course not, because vitamin D doesn't act by itself to prevent the immune dysfunction that causes multi-organ system failure. Everything is involved. If you're low on vitamin D, you're probably also low on B12. You're probably also low in vitamin C. All of these things need to be taken together in concert, and overall nutrition needs to be looked at as opposed to one individual vitamin at a time. And if the community at large is waiting for that kind of data, we're looking for the data that show that giving vitamin D will prevent death. That study will never happen. First of all, it won't happen. Second of all, it won't be funded. Third, it's never going to show any difference at all. Why? Because you need everything all at once. This is not an issue of one vitamin at a time.
Absolutely. And then, I mean, just considering the diet in America, the access to well-grown, great foods. I mean, when it comes to deficiency, it's got to be pretty prevalent at this point. If you can just take us back to the reason, so supplements are not FDA approved because it's a huge study that's required. I mean, I know that even just for those of you who have gone through pregnancy, I remember there are so few things that are approved where there's one category A, and the reason being that they just aren't going to.
I don't know if you can hear me, but just to interrupt a little bit, supplements do not require FDA approval. So there is no, I guess I mixed that up a little bit. When I say that for the use of supplements, there will never be FDA approval required. But unfortunately, the medical community has been trained by the FDA that the only way to prove the efficacy of an intervention is using a double-blinded placebo-controlled study. Does that make more sense? We will never have FDA approval really for any supplement, but in order to use them therapeutically, the medical community is looking for the kind of data that will never exist. Double-blinded placebo-controlled studies with an individual vitamin. And I think it's important to stress that these are vitamins. They have a very, very high margin for safety. Of course, just like with everything, there is the opportunity for toxicity. But I think it's important to note that we know from basic science that each one of the different micronutrients is involved in hundreds and hundreds. Each one of them is involved in hundreds and hundreds of enzymatic pathways that ultimately all regulate the ability of a cell to create energy. Without energy, it can't stay alive. Without energy, it can't contract as a muscle. Without energy, you cannot have cell-to-cell communication in your brain or down your spinal cord. And I think when you look at the basic science, to try to tease out the individual roles of each of these individual vitamins and say, let's see what happens if we just replace this one, it's not a reasonable expectation. They're too interlinked. And I think it's also very important to point out that this process that physicians have become very, very comfortable with, based in, again, sort of FDA processes, is B12 is not the same as a brand new molecule that's being used to potentially treat high blood pressure. You make up this new molecule, somebody comes out there and says, hey, this molecule can fix high blood pressure. Well, of course the FDA has an approval process because no one's ever heard of this molecule before. They have to demonstrate that it's safe. They have to demonstrate that it is bioavailable. They have to demonstrate that it does what the manufacturer says it does. Does it lower blood pressure? They have to demonstrate very clearly what the side effects are. And only once all of those hoops are jumped through can the FDA tout it and give it its approval and say, this is a new high blood pressure medicine, brand new molecule. We know lots about it. That's not the case with vitamins. We know from basic science that we need these vitamins. And what no one has been able to put in one place are studies that show that the need for vitamins, the utility, the sort of exhaustion of micronutrients is different in different disease processes. Why that happens, how that happens, and how to fix those discrepancies is not something that it should be necessary to use a double-blinded placebo-controlled study for. This is not a new molecule. This is all basic science. We know it's safe. We know it's necessary. And just because no one is trying to figure out exactly how the Krebs cycle in Parkinson's disease is changed and whether or not we need to tweak NAD or tweak FAD or tweak any one of the B vitamins, that is an unreasonable level of evidence to expect from something that we know to be true from biochemistry.
Yeah, I mean, that makes all the sense in the world. And I think that there are probably a lot of people listening who are taking a big, deep breath going, oh my gosh, yes, this is what I've been waiting to hear from somebody who, like you, has all of this knowledge, because it almost feels like those of us caring about the nutrients and the supplements and caring about these things without the deep knowledge that someone like you has, you feel kind of crazy. Like you're one of the crazy hippie weirdos that, believes in healthy living. So, I mean, what is it like? I know that in your, I don't want to call it like, I guess it's in your clinic, there are options for people, but are you also working one-on-one? And what is it like for someone coming to Privy? What can they expect, and what kind of things can they bring to your attention?
So one of the big things, one of the reasons that I set up my clinic in the mall here in Chico, of all things, is for one primary reason, and that is access. It is so difficult in Northern California to get in with a primary care doctor. It is so difficult then to build a relationship with them. And all of this is sort of limited by the fact that in order for primary care to work from a financial perspective, the typical primary care doctor will have to see 25 or more patients in a day, which means that each individual patient is going to have around 7.5 minutes. And that's barely enough to do any kind of medication management for things that the primary care physicians are really experts in: treating your high blood pressure, treating your diabetes, treating your high cholesterol, treating your heart disease. To expect to be able to do that in people who are getting progressively older and progressively sicker in a 7.5 minute period becomes really difficult. And the main reason, again, that I've set myself in the mall of all places is to have my front desk be a source of education to the entire community. I have had patients who've approached the desk and said, my blood pressure is 200/100 all the time. I have patients who approach the front desk and say, I have been suffering from migraines to the point that I can't go to work anymore. And these are things that when my nurses are able to speak with them for a few minutes and then pick up the phone and call me, I can give them a couple choices. I do see patients on a concierge basis, which allows me over a 3 to 6 month period to kind of dig in a little deeper and help them get some things done. Of course, because I don't work through insurance companies, it's imperative that I kind of know what the patient is dealing with in terms of how I can make referrals for them, how I can help them by writing prescriptions for them, or at least altering their prescriptions until they can get in with their primary care doctor. But 9 times out of 10, most people are just coming in because they don't feel well. And they have oftentimes vague histories, or it seems like vague histories of a little bit of depression and a little bit of anxiety and a little bit of stomach upset. And then it's easy for me in a conversation, either in person or on the phone, to kind of say, it sounds as if you might be helped, not cured, but it sounds as if just talking to you about your diet, talking to you about your lifestyle, talking to you about the medications that you're on, you may be low in a variety of different nutrients, and let's see if we can give you safe doses through an IV. And of course, IV fluids are very, very helpful for lots of different people, especially for the elderly, and see if we can move that needle a little bit. And it's always amazing to me that when you talk to someone who has never eaten a green vegetable in their entire life because they hate green vegetables, or you talk to someone who says, well, I don't have a lot of money, so we eat a lot of boxed, pre-prepared processed foods, or they're coming in because they're heavy. it's pretty easy to identify what potential micronutrient deficiencies they might have. And it's also easy to kind of move forward when you know that more than 50% of the population has some magnesium deficiency. When in an overweight population, you're talking about 80, 90, 95% of those patients who do not take supplementation have profound vitamin D deficiency. For patients who are vegetarian and are complaining of depression and anxiety, well, meats are some of the best places to get high doses of your B vitamins. And I don't know if you knew this, but you can take a perfectly normal, healthy person with no depression or anxiety, and when you deprive them of B vitamins, that is sufficient to cause them to have depression and anxiety. So if people can be helped to feel better and are already on antidepressant medications, and I can help them further by supporting their actual cellular physiology, then the antidepressant medications will work even better. But the idea of flogging someone's physiology with prescription medications when their underlying cellular nutrition is lacking is not necessarily giving patients the benefits that they could be having. It always seems to me, and this goes back to my training at Stanford, that underlying nutrition is going to be the basis of successful treatment with or without prescription medicines.
I mean, yeah, absolutely. I am curious. So, how much of what, when you're working with somebody individually, how much of what you're doing is going to be in your office through IV? And then is it also kind of like, now this is what you're going to be doing at home and this is your continued care? And, or is it all kind of this IV?
Well, I talk to people a lot about lifestyle. I talk to people a lot about the quality of their nutrition. I don't know if you're familiar with the way that Americans eat as being referred to as the standard American diet, which spells sad. It is sad, right?
Yeah. Yeah. And
Right?
now it's like cheaper for me to buy Cheez-Its than it is to buy grapes right now. Literally.
It is so awful. And this used to make me a little sick to my stomach when I was working, doing my rotations in primary care, family medicine, internal medicine. It would break my heart when you have to, as a resident, tell people you need to eat healthier, you need to avoid processed foods. And they're not educated, don't have a great living, multiple kids at home, given a choice between buying 3 apples and buying a week's worth of macaroni and cheese. Of course, their vote is going to be with the macaroni and cheese. That was one of the most frustrating things, was trying to advise people with no means or poor means to kind of support themselves how to eat healthy. It's not reasonable for a lot of people. And that's heartbreaking.
It is heartbreaking.
Yeah.
It absolutely is. And I mean, whatever, we can go down a rabbit hole of how, like, we sell the exact same, we have companies that sell the exact same products in different countries that are far more nutritional. We
Yes.
just don't hold the same standards here. Like, it's just unbelievable to me, but
it is crazy.
anyways.
We actually had an exchange student from Germany here who, while she was here for a semester, she developed this ungodly affection for what do you call the hot Cheetos? What are they called? The Cheetos that are
Takis or the flaming hot,
flaming
Takis or flaming hot Cheetos.
No, flaming hot Cheetos, right? So then she went back to Germany and we went to go visit her. And the only thing she asked for were the flaming hot Cheetos. She said I couldn't stop eating them, couldn't put them down. And they taste completely different from the flaming hot Cheetos that are available in Germany. And she said, I know that's the case because in Germany, I can eat them and my fingers don't stay orange. When I eat the ones from the US, my fingers are orange all day long. And that's a sure sign that I'm getting what I want. She was so cute. She was so cute.
Yep. All that healthy dye, red dye for you. Oh my gosh. Well, okay. I want to go back to you waitressing for the mafia. I need to go back to so many of these topics, and I know we have so many different areas to discuss, but I just think that you are a gift to, I know, my audience, our community, and hopefully a much larger and broader community. And I hope that I can have you back on here because I know that I'm going to get so many questions for you just based off of this conversation. But most of all, I'm just grateful that I'm grateful. I mean, I'm grateful to know you, but I'm grateful that there is someone really speaking up about this with the knowledge, with the understanding, and with the drive to, make changes for people. I think so much of my dad, who, I mean, he had a triple bypass, but if it hadn't been for the fact that he was with my brother and my nephew, who are both trained paramedics, at dinner that night, he would have gone home and gone to sleep and had, a massive heart attack. And it would have been that. And, now he's on tons of medication, which he hates. And he's so good about his diet. But I think of him and I'm always like, I need him to just move here because I know that you can help support him. He will do anything that a doctor tells him to do because that man wants to see his grandkids grow old. But but it's frustrating knowing that his only options are to just keep taking 20 pills a day. And he would do that, but it doesn't make him feel good either,
So there's a lot to be said. I'm glad you brought up this. Do you have a couple more minutes? Let me just say a little something about this. So if your dad started to experience chest pain, and this speaks to just sort of the last couple things that I'd love to drive home about my theories regarding supplementation and why I care deeply about being able to, for sick people like your dad, provide supplements aggressively, safely through an IV. If your dad were at the dinner table with your brothers and he started clutching his chest saying, I'm having crushing chest pain, I'm having a heart attack, if I were there as an anesthesiologist, I would not hand him a bunch of pills and say, here's a bunch of pills, and I hope you feel better in around a half an hour. That's not going to happen. And when those sorts of situations happen, I start an IV. I give medications in very specifically and targetedly with dosing that is very, very targeted and specific. And when I give them IV, in theory, I can see an immediate effect. And that is true, for instance, whether I'm trying to prevent someone from having a heart attack progress. That is true also, to some degree, of trying to use micronutrients as an intervention, which is the way that I like to think about them. He may have also, so for folks who have heart disease, they may have high cholesterol, they certainly have high blood pressure, they may or may not have a little bit of diabetes or pre-diabetes, but one of the labs that shows up in patients who have heart disease or demonstrated to have heart disease is an elevated homocysteine. And it turns out that homocysteine, which is associated with cardiovascular risk, can be to some degree reduced and made better with aggressive vitamin B supplementation. All the vitamin Bs can tend to help reduce that homocysteine and, in theory, reduce your risk. Again, those exact connections have not been made in very, very rigorous science. But doesn't it make sense that if homocysteine is a manifestation of inflammation inside the blood vessels, that the use of micronutrients to reduce and regulate and stabilize that inflammation could be helpful? Also, so that speaks to kind of why I like to give things IV, because I know what the dose is. I know that it's bioavailable, and I don't have to trust people's guts. I mean, even by the time most people are 35 or 40, I would say 60% of the population has some little bit of a gut issue, a little bit of gluten intolerance, a little bit of irritable bowel syndrome, irritable bowel, a little bit of constipation, a little bit of diarrhea. And all of these things speak to a gut that may not have a normal functioning microbiome. It all speaks to the fact that there's underlying inflammation in the gut that's going to prevent you from absorbing certain types of vitamins. And then once they are absorbed, because of the way our gut works, everything gets filtered out through the liver, such that the idea of heroic doses of vitamins can never really happen because so much of it just gets filtered out when it comes from the gut. When you give something IV, I can be guaranteed that before the kidneys get to it, that for at least 10 or 15 minutes, you have extraordinarily therapeutic doses of micronutrients that are spinning around in your bloodstream, which are potentially very, very, very well taken up by cells. Micronutrient levels in the bloodstream are really not an indication of overall nutrition, because in the bloodstream, they're not where they need to be. What we need to do is create better ways of looking at intracellular levels of these micronutrients, where the micronutrients can be used by the mitochondria to create cellular energy. Having it all spinning around in the bloodstream gives us a clue to what's going on, but it really doesn't tell the whole story. So giving things IV, from my perspective, as an anesthesiologist and as a critical care doctor, my relationships with people are better when I'm talking to someone with an IV in. That's my relationship with you would be better if I started an IV on you.
And I think that all I think of is how many times and how many people I've spoken with, and it's happened to myself. It's like right now I can't get in with a general practitioner. Like I can't, like it's months out. I'm like, well, I need to see somebody. I don't have time to wait for that appointment. That's going to be an hour and a half long, where you're not going to work with me on anything, so that I can book another appointment 4 months out. It's very frustrating. But at the same time, we go in and we say, okay, I need my blood work done. And I know that I have hormonal issues up and down, right? I mean, it's my endometriosis, it causes cystic acne, it causes lack of sleep. I know that this is going on, but I also know that every time I've gone in and gotten blood work done, they're like, it's normal. It's in the normal range. Everything is fine. And I feel like this is just so incredibly common for everybody, everyone I talk to. Yeah, I went and I got checked out and my hormones were normal. Everything was normal. I had enough of this, that, and the other. And so you speaking to how that's not exactly the best, way to tell.
I think hormones are a whole different ball of wax, truthfully. Can you hear me okay?
Yeah.
Hormones are a whole different ball of wax. But I think even with regards to both hormones and micronutrients, there's not really a lot of acknowledgement that there's a lot of variability from person to person. The nutritional needs of a healthy 20-year-old, which is what the recommended daily allowances are based on. And I think while they're being updated now, historically, the recommended daily allowances of vitamins were based on healthy 20-year-old men in Iowa. I don't even remember where they're from, but now they're starting to do a better job of kind of taking a broader swath of the population to look at recommended daily allowances. But regardless, healthy people, sure. Eating healthy diets, sure. We know what their recommended daily allowances are. What about for someone who for 40 years, starting at the age of 20, has been eating processed foods, who doesn't like vegetables, who is sedentary, and who suffers from a little bit of gluten intolerance? This is the picture, the description of a nutritional desert. And so to make that same sick 60-year-old live by the same, think that they
you also like
that the same rules apply to him, it doesn't make sense. I don't need an FDA trial to demonstrate that this patient needs more nutrition than the healthy 20-year-old. I don't need a study on that. That should be obvious. But quantifying how much they need is where I have a hard time kind of defending myself against the hardliners who will say, well, where are the studies? Where are the studies? Who's going to do those studies? And just because there is an absence of evidence, right, that doesn't mean that that is evidence that an effect, a positive effect, is absent. Those two things are not the same. Oh, well, there's no evidence. Well, that doesn't mean it's irrelevant, right? And that's sort of the mindset that certainly happens in Western medicine. Just because the FDA has set this bar, and let's be honest, who are the only people who can actually get over that bar? Big Pharma. Who else has that kind of money to go through thousands of people in a double-blinded, placebo-controlled study? And I am not trashing Big Pharma. I think that Big Pharma has an opportunity to potentially cure cancer, to really find meaningful interventions for everything from psychiatric disease to heart disease. Certainly, I think with semaglutide GLP agonist, Ozempic, they're onto something. But Ozempic, in theory, GLP agonists, they're really too small. They don't meet the criteria for being able to be patented. And yet somehow they've gotten a patent on it. The molecule itself is not patented. So I can't get into that. That'll start to frustrate me. But
I want to eventually.
Yes, I know, sorry. But I think it's very, very important for people to understand that physicians have their hands tied. There is no physician on the face of the planet who went to medical school thinking, I'm dying to see 35 patients a day and make around $40 every time I spend 7.5 minutes with one patient, and to be told what to do explicitly by insurance companies. No one goes into medicine for that. And it's, again, nothing against insurance companies, nothing against big pharma, nothing against physicians, but the people who are suffering from all of this are the patients. There's a lot of dysfunction in the way that care is delivered. I don't have an answer for it. I really don't. But what I'm trying to do is kind of step to the front of the stage and just say, I'm here. Ask me any questions. My desk at the shopping mall is a place where you can ask questions. It's a place where if someone has a quick question, I can pick up the phone and chat with them, and then we can make an appointment to come and see me as a concierge physician. I certainly think that most people who are living with dietary inadequacies now are dealing with the manifestations of decades of poor nutrition. And that is difficult to fix with oral supplements. For someone like you, to be honest with you, Katie, you're young, you're healthy. You can probably take oral supplements and have it make a difference in the long run. But if I have someone whose vitamin D is in the toilet, it could take a little while for that to come up with oral supplementation, but I know that I can fix it with one injection. They will walk out of there with their vitamin D deficiency fixed. And that need to do that comes from my training as a critical care doctor and anesthesiologist. I can't mess around hoping that someone's going to get the results that I want them to have over months and months and months and months. I want someone to show up in front of me, say, we have a problem, and I'm going to fix it. That's my training.
What you're offering is solutions, and
I think so.
And I feel like we're so lucky to have you here. I have all kinds of business plans for you so that more people can gain access to you. As I've mentioned, I'm like, you need to be everywhere. You need to be everywhere.
I love it.
You need your own WebMD. Thank you so much, Nerissa. I can't wait to have you.
Of course. Yes, I really appreciate you having me on the show. And I'm looking forward to talking about we have so many topics to talk about that we've already touched on. So many. Yeah. I'm excited.
I can't wait to hear everyone's response to this, because I know it's a topic that I don't often get to get into, because I don't often have people as incredible as you and so knowledgeable about these subjects, with such vast experience. And so I just appreciate you taking the time, and I cannot wait to have you back. If you have any topics that you are interested in having Dr. Prieto touch on, please reach out. You can go to the show notes. You'll see every different way to reach Nerissa. And if you are in Chico, go check out Privy. You will not regret it. Even if you're just getting your hangover fixed, they will take care of you.
Yes, I'll do that too, and it won't suck. I will say that you can check out my website. There is you can check out my website. It's it's privyhealth.com with two V's. PRIVVY health.com for some really good basic information on micronutrition and micronutritional supplementation, as well as check me out on LinkedIn, Nerissa Prieto.
Everything linked in show notes, so you don't have to memorize it. But thank you so much. I can't wait to hang out with you and have coffee again, to be completely honest, and
we'll do it.
Have you fix my neck, because I am literally dying. All right, you guys, go forth and slay.
Okay. Thank you so much, Katie. Appreciate you.
All right, there it is there. Thank you so much for joining us today on Level After Next podcast. Go ahead and subscribe so you don't miss anything. Or if you really don't want to have any FOMO, head over to levelafternext.org, where you can catch up with all the things. Peace out.